this is not on. This is on. Okay, thank you. All right, I'm batting 1,000 already. I can tell that. Well, thank you for coming today. I see a lot of familiar faces. I know this is Liver 101, but there's probably some of you here that could give this lecture too. And you're here instead of the pool, so I think that's also important because it's very nice outside today too. My job today really is to kind of give you some information, open a conversation, take your questions, and hopefully this can be as interactive as possible. I'd like to, if you have a question during, be happy to take it, but if we could save it to the end, we'll ask you to repeat the question so that everybody in the audience can hear it. So, with that, how many of you have seen this slide already in this conference, or at least before at some point? Well, if you haven't seen it, you're going to see it definitely, since this is 101 and you may not know much about the liver, this is the first case of Alpha-1 antitrypsin ever described. And this is what, on a slide where you see the normal protein bands, this is normal. This is Alpha-1, where it should be, and it wasn't there, which led quite a few scientists to start this path of investigation to get to where we are today. So the questions I want to cover are, what is liver disease? What are the symptoms of liver disease? How do we make the diagnosis of liver disease, not the diagnosis of alpha? What are the treatments and what can you expect? And a few other topics kind of along the way. So it's easy to know, before this conference or before you were diagnosed, you may have never thought about your liver and what it does for you. The lungs, I think, are easier. You can really feel that. You feel short of breath. You feel like you're coughing. You have some symptom. But the liver generally doesn't give you a lot of symptoms. And it's because it's just sitting there quietly in the background doing its job, right? It takes everything that you eat and drink, and it converts those nutrients into energy and stores it away for you to use at a later time. A very important function of the liver is it detoxifies your blood, or kind of cleans the blood out. It's like the oil filter in your car. It just keeps things running smoothly. I'm trying to use that kind of analogy. I once had somebody call it the garbage can, which I didn't like that description, but maybe that's the right way to do it. And it processes all the medications. A lot of medications that you take actually aren't active until they are transformed by the liver into something that can be more useful to your body. It's very important. A normal liver stores a lot of vitamins, lots of minerals, and a very important source of sugar, especially overnight while you're sleeping and you're not eating. And it makes bile, which helps you digest the fat. And if you come to this conference and if you come to the dinner tonight, and although you get very well fed, and so your liver's going to be working overtime while you're here. I'm not going to mention the bar because that's a different subject. That's a different subject altogether. It's going to be working overtime. So what is alpha-1 antitrypsin? It is a very, very abundant protein in your body, and it's primarily made by the liver, and that's why we're talking about your liver. Secreted out into the blood, and I'm sure Dr. Brantley probably went through the genetics with you, but the normal is M, and the abnormal is Z. So if you have 2 copies of M, you have a blood level that's in the normal range. To get liver disease, I think that you need to have 2 copies of the Z, or an S and a Z. And there are some unusual, there are a few M's that are very rare that are associated with liver disease, and in addition to F and I. So there are a few things that are more uncommon in an uncommon genetic disease. So what happens is that this protein that you make, the alpha-1, the Z, folds abnormally. And that folding abnormally makes it stick together and stay inside the liver. If you can't get out of the liver, it can't go and do battle in the lungs with the neutrophil elastase, which is where it needs to be. And so if you test normal, if you're a ZZ, your level's going to be low, typically less than 20. Sometimes it's even lower than that. So here's kind of the cartoon idea of what's actually happening in the liver. In a normal MM liver, this is the nice normal alpha-1 antitrypsin protein that's being made. And then within the liver cell, and within specifically a part of the liver called the endoplasmic reticulum, the alpha-1 folds into the nice, normal-looking picture. Now, this is my cartoon, not the fancy drawings that you saw with Dr. Brantley. But this is my idea. So you have nice alpha floating out in the bloodstream, going to where it needs to go. Some of it, that you make too much, you don't need it. A small proportion of it is targeted towards the normal processes in the liver that break down the alpha that you don't need. In a ZZ cell, I want to show you things that are different. Just first of all, much bigger. The endoplasmic reticulum gets very swollen and full of alpha, and it sticks together. So because it's folded abnormally, sticks together, can't get out. And this is what a ZZ individual was represented. You may have because you have increased collection of the alpha-1 in the liver, the liver is actually working hard to try to get this cleaned out. Because I told you the liver is a factory, right? It's making all your body's proteins. And like any good factory, it has a quality control mechanism. It doesn't want to put out a product that's not folded right, or that's maybe not active like it should. So it won't let the abnormally folded protein out of the cell and into the system. For the most part, you do have some that gets out. So what does that look like if I was to do a liver biopsy? Which I would love to do liver biopsies. Just ask the certain people in this room. They don't have to volunteer because that's a HIPAA violation. So this is normal liver. And then this actually is what the alpha looks like. There's a special way that our pathologists look at the liver tissue under the cell, and they can stain, and this is the polymer, the globules stuck together, and this is an up-close version, but there's a lot of alpha in this particular liver. What we've seen in our study is that this is highly variable. There are individuals who are ZZ who have very little of this alpha in the liver, and there are individuals that have lots of alpha in the liver. So even though all of you in the room may be ZZ, your liver is affected differently by it. And so I don't know the answer to the question yet. Is it because of where I took the biopsy, or because you are affected differently? Only time really will tell and give us the answer to that kind of question. So this is an actual picture. This is an electron microscope picture. This was published quite a few years ago. But you can see this in my cartoon where I was trying to show you how the liver endoplasmic reticulum was swollen and full of alpha. This is what this is an actual picture of in the cell. And then this is how how it's stuck together in these formation of polymers. This was actually the first description of where we started to understand this concept and the idea of the polymerization of the alpha and why that might be important. So the collection of alpha in the liver in the form of, it's not just polymers, it can be smaller, it can be larger, but it's that process that triggers the liver injury through several different mechanisms, we think. But there's scarring, there's fibrosis. The cell that has too much alpha may not be the healthiest cell, and so the liver, as it tries to clean it out, you may end up with more liver damage. Now, the polymers tend to collect around in certain areas in the liver, and that's where we see the scar starting to be laid down kind of carefully over time. But we all know from our clinical experience and from talking to other alphas, and you will get that sense at this conference, that everybody has a different history with their liver. And some people have severe disease that comes very suddenly. Some people have kind of at a very young age. And some people aren't diagnosed with liver disease until they're in their 70s or 80s. The oldest alpha I met was 85 years old, and he presented with liver disease, and that was the first time he ever knew that he had Alpha-1. So there's just a huge variety of the clinical presentation. So we know there are definitely things in the environment, and then other genetic modifiers, the way that your liver processes the alpha, the way that it's cleared out of the cell, or other response to liver injury that makes people more or less at risk. Those things we don't know yet. That's why we're doing this study. Although I think the study may give us more questions than it actually gives us answers, but at least it's a really good start. So, but the polymers actually, maybe the reason I want to emphasize them is it may be the key to treatment. It may be sort of the part of this process that unlocks the key. Because at least in the early, where we are right now, cleaning the liver out, getting the polymers out of the liver is one of these early trials, or preventing the formation of the accumulation is the other strategy. It's either get it out or clean it up or prevent it from happening. So liver disease in general, we don't think happens overnight. It's slow because of a chronic injury. So you tend to have, in most liver diseases, not just alpha, either some degree of inflammation, some degree of scarring, which is what fibrosis is, and eventually you end up with liver cirrhosis. It's not a process that happens overnight, that's for sure. You start somewhere normal and then end up with more damage. So I want to go now I'm not a pediatrician. I think there is one in the room, but I won't mention him by name. And what we see, liver disease in children and liver disease in adults is different. It's similar in the sense that for children, the symptoms are highly variable, but children can present very, obviously much younger. They can present with very severe symptoms, such as liver failure, or they can be completely asymptomatic and be diagnosed because they have a sibling. And it's just like in adults, where there's a really wide variation of this disease. You can even be diagnosed for the first time as a teenager. So some of the early research in liver disease in children, a lot of both parents and physicians want to know, well, if I have a child that's a ZZ and they have liver disease, does that mean my other child that's a ZZ, are they automatically on that same pathway to have liver disease? And the answer is probably not. Probably because of the other modifiers, other genetic conditions, other things, the risk of a similar course is somewhere around 20 to 40%. So maybe some of the other genetics would predict, but not completely. So, and even if your child has advanced liver disease or liver scarring, then the clinical course seems to be very slow and very stable, which I think can be reassuring to parents with children that are at the initial time of diagnosis and over with time. So this study actually was just published in the last year. It's part of a very large network because, as you know, Alpha-1 antitrypsin is not too common. And so this study called the LOGIC study, which is longitudinal study of genetic causes of intrahepatic cholestasis. So LOGIC is much easier to say than that. The goal of this, because children often present with cholestatic liver disease, which we don't see in adults, they want to enroll and follow and just describe what happens to children. And so this is the first report from this study, and where children have been followed up to 10 years. And to be in this study, you had to be a ZZ, an SC, or a sibling of a sibling who was a ZZ. And the goal is to get 400 children in this study. They're not quite there yet, but they're pretty close. So this report that was published had 280 patients or so in it, which is quite a large number of alpha children. And they were able to really describe two different clinical patterns of liver disease. So to be in the study, you had to have liver disease and have a diagnosis, but it was either mild liver disease or more severe liver disease. In the mild liver disease, you didn't have portal hypertension, but had maybe abnormal liver tests. And in severe liver disease, you'd either had a liver transplant or had portal hypertension. Now, portal hypertension, I don't know if you guys are familiar with that term. What does that term mean? It's where you have increased pressure across the liver that's related to decreased flow through the liver. And typically what you see is a low platelet count and a big spleen, especially in children, which is how they defined it in this study. And what we learned from this study is that about a third of the children had portal hypertension, but those who were liver affected, both mild and severe, they had normal growth patterns. They were leading normal lives. Their quality of life overall, both for them and their family, was quite good. And so I thought it was very reassuring in a lot of ways. You get this diagnosis, but children tend to grow and be healthy. It's only a few, maybe 3% up to 5%, that maybe go more towards liver transplant or more severe disease. So even though it can be a very dramatic presentation, a lot of the children, when diagnosed, will get through it and lead a pretty normal life. So, and the complications from portal hypertension are pretty uncommon. And one concept that's out there is that the earlier your child is diagnosed, then the more severe the liver disease may be. This study actually gave us an idea that that might not be right. That in fact, the children who with severe liver disease and the children with mild liver disease were diagnosed both at exactly the same age, which is around 1.5 years on average. So this concept that, oh, well, you were diagnosed really early, that's not good, that's probably not the right message that we want to send to our families and our those who are affected. It's you have it, we don't know what's going to happen, but it looks like based on this and a large number of alpha children, most of them are going to be okay. And so, and the goal of the study is to follow over 10 years and really get an idea. Now, where this study falls down is that there are a lot of you in the room that probably weren't diagnosed as children. You were diagnosed as an adult because we don't screen, and so it doesn't really represent the full spectrum of alpha, but what it represents are those that are the children that are symptomatic, and it has all the inherent problems of kind of a study in this way where you're only following what happens to identified people, but in a rare disease, this is what we have, and I think this is actually a good data for all of us to learn from. So what about adults? Well, I think the biggest thing is age is a risk. The older you get, there's a risk for a lot of things. But it's the older you get for cirrhosis, it seems to be at age greater than 50, the chance is a little bit higher. This is based on a lot of old data, looking back retrospectively. It's kind of subject to the same types of biases that the children's study is, but we know from the National Heart, Lung, Blood study that cirrhosis was a big cause of death in individuals who didn't smoke, meaning that if you're affected with alpha, you may live a long time. If you're not a smoker, your liver may ultimately, it's not the end of the world for everybody, but it is a risk that you're at risk for cirrhosis. And this risk of liver cancer is also increased. This data is very, I don't want to scare you, this data is not very good. It's out there, but it's not really, I'm not so sure how alpha makes you at higher risk for liver cancer, but it's reported as a risk. And clinically, we don't see it a ton, but it's out there reported. So symptoms of cirrhosis, like I said before, you don't really get a lot of liver symptoms until you're pretty sick. And it can happen even though the damage doesn't happen quickly, once you become symptomatic, things can change very fast. You can have edema in your legs, you get swelling in your abdomen that's ascites, you can be jaundiced, you can get varicose veins in the esophagus, and then difficulty concentrating, confusion, memory loss, sleepiness, kind of if you're really bored, that's how you are now, but if you're not, that's what we call that encephalopathy. I have patients ask me, but doc, I'm 65, I have that anyway, how can you tell, what's the difference? And so, but it's different, you know it, and your family knows it when you can't quite concentrate the way that you should. But these are all symptoms of pretty advanced liver disease that you see when somebody is pretty sick. So if your doctor is monitoring you for liver disease, or if you were diagnosed with liver disease, it can be based on symptoms. It can be, how did we come to the diagnosis? We do x-rays. You can have an endoscopy. This is, I think, the best way to look at the liver, which is an ultrasound. It takes a picture. It doesn't expose you to radiation. It's not as expensive as some of the other tests, and you can do it over and over and follow. You may have a CAT scan, same idea. This is a normal-looking liver here to kind of get a picture of it. Or an endoscopy. This is what varicose veins look like in a picture from an endoscopy. These are signs of portal hypertension if you have liver cirrhosis. Or you could get a biopsy. A biopsy, this makes it look so simple. A biopsy basically is that you take a small needle, numb up the skin, take a little bit bigger needle, and go in and take a sample out of the liver. And you go in between the ribs, right underneath the lungs. And does it hurt? It does hurt. It's a little uncomfortable. Everybody deals with pain a little bit differently. Some people, it's not a problem at all. So I'm just that good. But there's some people that it bothers a little bit. So in those who have alpha, if you have emphysema, if you have expanded lungs, then you just have to be pretty careful that the lung is not in the way or not in between you and the needle. So we were looking at, so that's how we get a picture. That's the most definitive way to know what's happening in your liver. We went back and looked. We've done a couple things, and some of you in the audience may have participated not knowing you were participating, because this was blood from the DNA tissue bank. If you submitted any sample to the DNA tissue bank, we went back and looked to see what your liver test looked like from ZZs. And the nice thing about the tissue bank is we have a nice collection of MMs. And so if you look, we kind of matched it for age and sex through the ZZs and the MMs. And you can see that the liver test, the ALT for men and women, your AST, the typical tests that we check for liver disease were pretty normal. And they looked exactly like an MM. You couldn't tell the difference just by blood work from an MM or a ZZ. The only one that was slightly different was this GGT, and it was definitely higher in those with ZZ. And since this, I started checking and recommending that physicians check GGT much more routinely. And then we also looked with the same data set across the age, because I told you age is a risk factor. And this is a retrospective look back, so ignore this. But here you can see actually those who reported liver disease and those who had abnormal liver tests were pretty similar all the way across the board. So we didn't find that age really mattered as much, because in every category there were individuals with both liver disease and with abnormal liver tests. But it wasn't the same group. As you can see, the numbers weren't the same. So I think this kind of spurred us on to do a little bit more work. So the predictors of adult liver disease, men seem to be at more risk. I'm not sure, that's uniform. We found that. Everybody else seems to have found that. There's something about being male that makes you at more risk for liver disease from Alpha-1. And in this study, looking back, individuals who've had childhood history of liver disease or jaundice tended to have more liver disease as adults. I have theories about why this could be the case, but it also could be that people who had liver disease as adults spent more time thinking about what happened to them when they were children, and maybe asked more questions or remembered more from their family about why, and that could also explain this. We'll see. So this is the data from our latest study. And what the message is that I think I'm a glass half full kind of person. And so out of all the people that we biopsied, this was the first 87 individuals, and we're a little bit higher than that now. But just over 2/3 didn't have what I would consider clinically significant liver scarring or liver fibrosis, which I think that's a good message to the alpha community. And this was all comers. This was everybody, any adult with alpha could be in the study, as long as you didn't have evidence of really far advanced liver disease. In this category, a little bit higher now, probably the final numbers are a little bit lower than this, but it's about a third, 30, just over a third that actually have significant, what I consider clinically significant liver disease, fibrosis stage 2. So if you look across the fibrosis scores, let me back up. So when we do a liver biopsy, we give a score, anywhere from 0 to 4, 4 being cirrhosis. And so what you can see really is that a large proportion of people, most people were here in F0 or F1, and even fewer were up here. And the number of men, though, clearly was higher the more advanced disease that you had. So What about this idea that can I be liver? You may hear people say, well, I'm lung affected, and you hear other people say I'm liver affected. And one of the questions is well, are you both? And my answer is you might be. You probably definitely are in some ways. I want to show you this information because you may know what your FEV1 is, but let me explain a little bit what you're looking at. This is that stage of liver scar from everyone that we biopsied. So this was 0. And then this number, you may not be able to see it from the back, but the important thing to look at is really just, this is the highest. We just broke FEV1, looking at lung injury, from FEV1 greater than 80 down to FEV1 less than 30. So from best lung to worst lung. And you can see that at 0, we saw no liver fibrosis in the best lungs and in the worst. Same in 1, all the way across from the best to the worst. Same for fibrosis score 2. It was across every stage of lung disease that you could have some degree of liver injury. And I will show you, so you're not just liver or you're not just lung. You're likely, there may be some of both and there may be neither, which is what this graph shows. This is the worst, the kind of the more, I wanted to know, or we wanted to know, what is the most severe? If your lung disease is severe and your liver disease is severe, because that's really the individuals that you would worry the most about. And this is only 22% of everybody that participated in the study had an FEV1 of less than 50. 18% had a fibrosis score greater than 2. This had one or the other, so the numbers aren't exactly what I showed you before. But I'd say 17% of the entire participation in the study had what I would consider clinically significant liver fibrosis and clinically significant lung disease with this FEV1. So about 20%, I would say, are most severely affected by both liver and lung. And I think this is something new. This is something, the information that the community has to think about when they're thinking about how do I evaluate my liver disease. So this is a question I always get. What if I'm an MZ? Because there's a lot of MZs out there. And I know that there's an increased risk for cryptogenic cirrhosis. Even in our own population, we've looked at this, and it's true. I think fatty liver disease plays a big role in cryptogenic liver disease, and there's a definite interaction between Alpha-1 and fatty liver disease. I'm not saying that you can blame the alpha for your fatty liver, but it definitely plays a role. I have MZ patients that we can see the same accumulation of liver disease, of alpha in the biopsy. So not a lot of treatments, but we can talk about liver transplantation in a minute. This is a study, carbamazepine, that you guys may be aware of. It actually helps clear the liver. That's the idea. The abnormally folded protein out of the liver, and it may help reduce liver fibrosis. I'll talk a little bit more about this tomorrow in the liver research, but there's a trial going on right now, and to be in this trial, you have to have very advanced liver disease, and they're looking to see if they can reverse that endpoint of portal hypertension. So fortunately, the liver transplant we don't resort to very commonly. It's indicated for people who have severe liver disease with failure or early stage HCC, and the idea is that it replaces the alpha liver and it corrects your metabolic defect, right? So you're no longer an alpha, so to speak. And the overall survival is very good. This is the latest data, although it's not real recent, but just looking at how people do after liver transplant, they tend to do quite well. So one other question is what happens to your lung function, right? If you get a new liver and you are making normal alpha, does your lung function improve or does it get better? Believe it or not, do you know how many patients we've ever actually studied in a very good way to get this information, as long as we've been doing transplants? 17. There's the largest series is 17 patients that have had a liver transplant and had lung function tests before and lung function tests after the transplant. And that's what this data is here. And it's very mixed. And so what you see is some people's lung function got better, some people's lung function stayed the same, and some people had a natural decline. That's not saying, normally as you age, everybody loses a certain amount of lung function over time every year. Even healthy people do. It's about 30 mLs per year. So we expect there to be some natural decline. It's just the concern is, what do you do? My message to you, the details aren't important, but if you have a liver transplant, if you're sick, you need to be following with your pulmonologist for sure after, because it may be a cure, but it's not, there's something more to it. It's not the complete answer. So, if you're diagnosed with liver disease or cirrhosis, you need to stop drinking, just period. No more alcohol. I know this conference would suggest otherwise, but you probably should not be drinking alcohol. Can you drink alcohol? Can you have a drink before a transplant, or can you have a drink if you're an alpha? That is your personal choice. There's no good data to suggest that normal, I'm going to put that in quotes, normal amount of alcohol would hurt the liver. And a normal amount of alcohol for a woman is 1 drink a day, and for men it's 2 drinks a day. But you have to ask yourself, how big is my drink? That is the most important question. It's supposed to be a normal drink. So that's a 4-ounce pour of wine. You can think about that. Or 1 beer, or 1 mixed drink with a normal shot. So that is 1 drink. Most people, when they pour a glass of wine, it's typically twice that. So just beware. I'm telling you, beware. If you were diagnosed with liver disease, tell your doctors that you have cirrhosis, and so they will check you for all the signs of portal hypertension. You need to be immunized against hepatitis A and B. And the most important thing you can do is what you're already doing, which is you're here and you're educating yourself and you're learning what to do and what not to do. And you're going to maintain a very healthy and active lifestyle. Annual liver test, an ultrasound on occasion. I need to update this since the new diagnosis guidelines just came out. So these are the questions we still have to answer, and that we're in the process of answering. Why some people are liver affected and why people aren't. Is there a way to follow liver disease early and track the changes? Perhaps, I think, and then there's a big emphasis on treatment and what we can do and cure, because that's where we're all here for, is to try to cure this and be done. So how do you help? You can participate in the registry. You can participate in the study. You can educate your doctor. I think sometimes people who are newly diagnosed don't know where to go and don't know that. I just want to empower you that this is a great place, and that to push your doctor to learn more about Alpha-1 so that you're getting the right information and the right treatment, and then educate others. Oh, and then that's it. I'll take questions. I'll be happy to entertain questions. Thank you very much for your attention.
Hi. Wow, that's loud. So prior to my Alpha-1 diagnosis, this was probably 10 years back or so, I had a panel done, just, typical blood work, and my liver enzymes all came back normal, but my ferritin came back elevated. And so when it was elevated, I was sent to a specialist, and it was checked like every 3 months for a couple of years, again, all prior to the Alpha diagnosis. Mm-hmm. And they went into further testing, and I was diagnosed with hemochromatosis on top of having the Alpha-1. So I was wondering if there was like a direct correlation, even though I didn't see ferritin on this blood test, if, you guys could do studies on hemochromatosis in conjunction with Alpha-1 studies to, how am I trying to word this?
To try to help you out, figure it out if there's a relationship. Yeah.
Yeah,
Yeah.
I mean, like earlier on, because I think that had there been any indication that I had Alpha-1 going on with the hemochromatosis diagnosis, that, I could have been started on augmentation therapy prior to that. The weird thing is, since I've been diagnosed with the Alpha-1, my ferritin levels have dropped back down to normal.
Are you on augmentation therapy
Yes.
now? So ferritin is tricky. I think there's about 4 questions in that question. So
There were, I'm sorry.
But that's okay. But let me just repeat to make sure I understand all of them.
Sure.
One is how good is the ferritin, and should we check the ferritin in everybody that's being worked up for abnormal liver tests? And the answer is yes. So if somebody comes to me for an abnormal liver test, I check them for all of those things first. Most people do. So you would catch a high ferritin. You should catch a high ferritin relatively early on. I think, and then do you pursue it? Ferritin can be tricky because it's an acute phase reactant, and so it can be high when there's a lot of inflammation. So if you have Alpha-1, it may or may not be elevated if you're sick or at the time. So is there a direct relationship? The answer is definitely maybe. So and how's that for hedging? So we looked at our liver biopsies, and every one of them who's had the study so far, we looked for how much iron was in the liver, and we've done genetic testing on the most common hemochromatosis. So hemochromatosis is another genetic condition, and it, just like Alpha-1, you either have 2 copies of the C282Y, which is one, or H63D, or some combination of the 2 of them are the most common. It tends to be, it's actually more common than Alpha-1. So if you have 2 copies of the C282Y, you are genetically have hemochromatosis, but you may not have the disease because you get too much iron in your system is the idea behind, is what happens. So on the biopsies that we did, nobody had genetic hemochromatosis in the study, but we did see some increase in iron. What the guys in the lab are doing now that's somewhat beyond me is looking to see, we think that there's some change in how the liver handles iron and how it's processed, and so, but it was in a very small percentage of individuals. So it's worth doing the genetic testing, but if you happen to be affected by both, it seems you fall in that category where I said other genetic modifiers. That's kind of where it is. So I think, yeah, no, great, right? But you know, and you can do what you have to do, which is keep a healthy diet and keep the iron out and be on augmentation therapy, which can help.
Thank you.
Okay, I have 2 questions.
Oh, good.
The first one you partially answered when you said that 17 people had actually been studied. So 17 people have been studied after transplant. And I always wondered, is this something that the brain is doing that doesn't allow the liver to know to induce the Alpha-1 antitrypsin into the bloodstream? Or is it, like you said, with the liver, inside the liver, the Alpha-1 is being stuck together, not allowed to go out? So if you put a new liver in, does it act normal? And if it did, then it would be the liver, not the brain.
Yes, I think it's the liver. So in these 17 people, they were able to check levels, and levels really reflect what's in the blood and what the liver's putting out. And so the levels were high or normal. So even with the normal level in these 17 patients, the lung function, some of them still decline. So I think it's probably more of a local effect in the lung that has to do with, the liver's not the only place that makes Alpha-1. The cells in the lung also make it. So it may be that's why there may be ongoing decline. I don't think it's the brain, though.
The majority of the production's in the liver.
Correct.
So then do you look for something that deteriorates whatever is it a polymer you were calling it, the sticky substance?
In a transplanted liver?
No, in just a regular person's liver, the antitrypsin sticks together. That's what inhibits it from getting in the bloodstream.
That's
so
in the
do you
ZZ
then
liver.
look for something to break down that sticky substance?
Yes. So your liver, your body can naturally break it down, but it's sometimes the idea is that you have so much of it that you can't keep up with the breakdown. But the key to cure or key to fixing the problem is a lot of scientists are looking at something that can bind or stick to the protein to make it fold in the right way. And if they can find just the right thing to stick the right way and make it fold the right way, it'll get out. So that's one idea for the medication, that it can bind and help it fold the right way and get out. So you don't change things, or you completely block the production so that it doesn't stick together. So those are different therapeutic avenues, you're right.
Okay, and we have one last question.
I'm an alpha that was born with the liver disease, and you didn't really talk about infancy. I was born right at the end of World War II, and I almost died. And I basically heard from my parents that I was born with my liver out of place, and I developed an enlarged spleen, and then it disappeared. And what's really weird is I did the liver test, and I have mild scar, but I have the lung disease. So I don't, what happens when, I mean, I did take very good care of myself over the years. I have, eating liver food and stuff like that. But why do you get it at infancy and say, my sister didn't get it at infancy, and we both are ZZ, so.
Well, I think that's what we don't quite know the difference between pediatric disease and adult disease, because one of the things is that in adult disease we think it's all related to the accumulation of the alpha. But when you're born, you don't have time to accumulate the alpha, and you have a cholestatic picture, and so there may be something that's different about how it happens. Reggie, do you want to tackle this one or no? We don't know. The answer is we really don't know. I can do a lot of hand waving. We just don't know. But I think you're that, when you were so sick, you're in that category of people that get better, get through it and get better. So if you guys have, I know we're at the end of our time, and I'm booked from now until 6, but find me, I'm around. If you have another question, I'm happy to talk and answer anything that you have at any point in time, okay?